Well, we'll keep this pretty informal. I just have some slides mostly just to put as background so you don't have to keep staring at me the whole time. So I'm just going to talk a little bit about this new thing that is kind of forming up, which is a multi-institutional collaboration with the Ghana College of Physicians and Surgeons to build colorectal surgery expertise, which is a mouthful, but I think is kind of a good way of putting it. So I'm just going to throw up here a couple different organizations, and I'll kind of walk through them. So the background of this whole project, which is essentially to build a certificate program for colorectal surgery and then eventually into a fellowship program for general surgeons, was my understanding of this is, so this has really been driven by Gifty Kwache, who, for those of you who were here, was last week or the week before, gave grand rounds, a great grand rounds. And so she's a colorectal surgeon at the University of University of Michigan. And she was approached by, and she's originally from Ghana, but then came to college in the US. And so she was approached by her contacts at the Ghana College of Physicians and Surgeons, which is sort of the equivalent of sort of like the American College of Surgeons mixed with like the medical board or the American Board of Surgery plus the medical board. They're not actually the true medical board, I should say, but those two I think are appropriate, sort of like ABS and ACS combined, supervising sort of the training and delivery of care in Ghana from sort of the provider perspective about some gaps in cover, sort of expertise they had. So they have a lot of general surgeons, but who treat a lot of colorectal disease, specifically, obviously the rectal cancer is one issue, but also stuff like anorectal fistulas, rectal prolapse, and things like that. And so there weren't really any colorectal specialists in the country. There is a group in Kolabu that I'll talk about a little bit more in a moment, but essentially they wanted to build more capacity around that. And so I think in discussions with her and also with Jonathan Alaria, who's a colorectal surgeon at the University of Arkansas, who's originally from Ghana and has spent a lot of time working in, I'm sorry, blanking country next door, but Togo, doing and also bringing over students from Ghana. They got to talking, and I think where the goal is really at this point to build essentially colorectal expertise in the country. And so I got sucked in just as a kind of a side story at the American College of Surgeons when I walked up totally underdressed because I was supposed to be going out to dinner, a very casual dinner with Gifty. And then she's like, oh, by the way, and this is your new boss, Dr. Noriaku, who's of course always in a suit. And so and then the conversation basically went, Leon's gonna be helping us with this great project that I hadn't told him about. And I was like, okay, great.
Now I can't say no.
And that was my first meeting with Dr. Noriaku. But we've also done this here with the help of Suda and with Bartley, and especially with our colorectal fellowship. I think this fits in really nicely with our teaching objectives for our group. So I put a couple other organizations on here, and the next two, Colorectal Surgery Associates. It's probably not a group that you guys most people are familiar with, but for those of us in the colorectal field, it is a really major group. So this is a private practice colorectal surgery group in Minnesota. And what that means is they have actually been running the longest standing colorectal fellowship in the country. And if you go to interview there, Luke Martin did their fellowship. If you go into their conference room, there's a wall with all of their graduates, and you actually literally will go through and look at all the people on the wall, and it'll be like the division chief of colorectal surgery at Brigham, the division chief at here. So almost every major program has been touched by the Minnesota program in one way or another, and they've been doing this for a very long time. And Ann Lowry is a colorectal surgeon who recently retired, but she was a longtime program director there, and also was the CEO of this private group. And so she has been involved as well in guiding us. And the important component here is that I put up ASCR's logo, not because they're officially supporting this program as of yet, but Ann Lowry is one of the past presidents of ASCR's and has been heavily involved in many levels of the organization. And so I think that sort of goes to bear that I think there's a lot of interest and a lot of expertise in education coming to this. And then the three main teaching hospitals that we've been working with, we've worked with, were Kolabu, which has a colorectal unit with specifically looking at colorectal disease, but they are not the sole providers of colorectal care, if that makes sense. And then Kath and the Cape Coast Teaching Hospital. So that's kind of just to give you some background of what work.
What do you mean by they are not the sole provider?
Yeah, so I think like I'm still figuring that out, but I think because they have multiple general surgeons, it's still this kind of mix of general surgeons, people, depending on how people get referred in, they may get care from one of the other general surgeons.
Gotcha.
So it's not like in our group, I think we're essentially most sort of really specialized colorectal care are going to come to the four of us. It may end up with them, and it tends to end up with them, but it's just like they still do gallbladders, right? Even though they have an HPB surgeon, right? Or a general surgeon. So I think it's more like that kind of situation.
Yeah, because they don't really have any fellowship trained or dedicated expertise.
No. I mean, there's a group that's very interested in it. And I think, they've done a lot of reading and they're aware of kind of literature, but yeah, they're not. And I think the system is not designed to kind of have that referral base either. And obviously there are a lot of issues about how a lot of general surgeons would feel about giving up, colon cases, for example.
Yeah.
So, yeah, we can come back to that in a bit. So I think the main goals of this, and I'm going to, because this is a closed group and it's recorded, and of course you'll share it with Gifty. I'm just going to say that I this is what I would put down as the goals of this program. I will say that we're still kind of working on the organizational piece. So there's a lot of times where I'm not always sure of what's going on, and I think it's just because we're still kind of working these things out. Not that Gifty's trying to exclude anybody, but just I think there's a lot of sometimes the discussions are smaller and they come back to the main group. But I think in the short term, and the short term being like this year, the goal is to establish a 1-year post-fellowship certificate program. So this is for people who've already finished the general surgery training and want additional training in colorectal surgery specific diseases and surgeries. And so it's a certificate program, and I'll go into kind of where we're at with that. But I think the long-term goal is to eventually establish a fellowship program in the sense that it will be part of residencies, but potentially kind of a branch point for people who are specifically interested in this area. So that's where this will go, I think, over time, or looks like it's going. So kind of the timeline of a lot of this, I think a lot of this probably have been going on when into the fall. But that's when I got involved, and there was a lot of planning involved. And I'll say that Gifty spent quite a bit of time collecting case volumes from each of the sites to make sure that there was, one, the case volume that we could actually train people to do these cases, and two, to kind of see what the distribution was like. So there's definitely different, I don't have the numbers up here, but basically there's definitely a spread in what cases are being done where. And in terms of, like, for example, let's say rectal prolapse, anal rectal fistula disease, and then rectal cancer, kind of the big three that we're seeing there. And then in January to March, there were a series of didactic online teaching. This is kind of a good example of this. I wasn't available for these, and so I actually wasn't sure that they were happening. And then when I arrived in March, I found out they did indeed happen. But I think Jonathan Gifty kind of drove this initially, but there'll probably be more of this as to come as I'll show you. So I'm going to talk mostly kind of about my experiences when I went out in March for what we built as sort of an on-site master's course. The idea being that it was one, obviously the usual meet and greet, get to know everybody, kind of get a feel for the lay of the land. But also the idea was to bring in established general surgeons and a few younger surgeons who are interested in colorectal surgery, and I start to do the training the trainers kind of process, even though we recognized that this was not going to be remotely sufficient. The idea was to at least get the general surgeons on board, create buy-in, and then start giving them some skills that they could then pass on to their trainees. So I'm just going to I'm going to use the pictures just kind of as a guide. So for our day when I arrived late on Sunday night, and on Monday and Tuesday we met in Corlebu, actually in the anatomy labs. And so each of the first 2 days we spent in the morning doing lectures, kind of going over I would say sort of core colorectal surgical principles. So for example, I talked about the oncologic principles used behind colon cancer and the resection margins for that. Jonathan talked about total mesorectal excision, which is kind of the core principle that drives rectal cancer surgery. Ann Lowry was talking about rectovaginal fistulas, and then Gifty was talking about the workup of cancer patients, specifically rectal cancer patients. And then the anatomy lab had arranged for us to have cadavers to do demonstration surgery, so we could demonstrate a lift procedure, a rectal prolapse procedure, a rectal cancer TME. And that actually worked out surprisingly well, although I would say that it was a real challenge because one, we had like 2 cadavers and only one was really usable. And then kind of disturbingly the next day, like they were like, oh, you need a fresh cadaver. And so they gave us like a fresh cadaver, like a fresh trauma patient from like the night overnight to demonstrate on. So Jane's smiling there. I'm kind of like, okay, let's, I guess, different systems. I don't know, I think we could get a fresh cadaver that fast here in the US. And then I just have a picture of us kind of demonstrating some of the procedures. So we were showing them, for example, TMA dissections in a cadaver, and then showing them how to do lifts and anal rectal advancement flaps. And then this is kind of the core group that was there. And it was important to kind of note that there's, real mix of like junior and senior people. And then there was a lot of leadership from the Ghana College of Physicians and Surgeons, people who were not necessarily practicing anymore, but were sort of influential in sort of the decision-making process, including the current president of the college. Wednesday, we took as a field trip day up to the Cape Coast. And I'll just, I'll talk a little bit about that, but I think it was actually a really good day in the sense that many of the people who were not necessarily from Accra, from the area, actually came along with us. And so we were able to spend some time chatting and talking and kind of getting a better sense of things. So in that way, sort of like a little bit of camaraderie building and getting to kind of just understand the culture a little bit better for those of us who are not from there. We actually drove by Gifty's old high school, which was kind of fun. She didn't want to get out and celebrate her being there, but we tried to get her to do that, but that was fun. And then we went to this canopy walk, and that's the middle picture is my kids. I brought my family with us, and so they're working their way across this canopy bridge, which is about 40 meters above the ground. And then the pictures below are from one of the Cape Coast is known for basically being where a lot of the African slaves were sold essentially to the Europeans and then transported to the Americas or the Caribbean. And so this was one of the smaller castles. We actually came the day after Kamala Harris was in Ghana, and she went to a different castle. But this is kind of similar, and it's of course very sobering and jarring. And there's a whole nother can of worms about cultural responses to that we can dive into later. Thursday was really a planning and discussion meeting at the Ghana College of Physicians and Surgeons. So we met in a conference room there and kind of worked through a lot of the logistics about what the exams would look like for the certificate program, what would the continuous sort of evaluation. So how are the case logs going to be managed? How are we going to evaluate that? How are we going to do M&Ms and provide sort of ongoing feedback to the people going through the program. And like many of these meetings, I'm just going to say that, most of this is initially about everyone has to get their say and get their sort of stake in the ground first. And then I think right now, actually a lot over email and Zoom, a lot of the negotiations are kind of going as to, where are they going to spend time? How are we going to kind of integrate it? How are we not going to impinge on other trainees' caseloads, things like that, especially if there's not a colorectal unit at like CAF, for example, where those cases going to come from, and are they going to be taking them away from other trainees? So a lot of kind of those small but very important details that can come about. Question there? Or,
no,
yeah. I think I'm not going to pretend to be a global health person, but I've spent enough time working in other countries to know that this process is not, I think, particularly unique or surprising in any way.
Not at all.
And the truth is, I think we are still trying to feel out exactly, make sure we understand what the college wants too as well.
Yeah.
And I won't even pretend if there's other political ramifications of that.
By the way, just as an aside, we've been developing an online academic global surgery Canvas course for people who are novices getting involved in global work, to kind of have some understanding of where things are coming from and what are the main principles and stuff like that, which will be open to anyone. We're going to at some point get it as a School of Medicine elective and a university elective, but for now it's just an online thing that Anna's been critical at trying to put together.
Yeah, no, definitely have to take a look. And I'll say there's a lot of other some of the other discussions also really revolve around reimbursement, and this is again not a surprise in global health. So rectal cancer, for us here in the United States, is a multidisciplinary thing involving radiation, medical oncology, pathology, radiology, and so the one strength is that the college does oversee all those specialties. But the other component is that a lot of this has to be negotiated with the Ministry of Health because it is not reimbursed. So for example, radiation therapy is covered in Ghana for breast cancer, but not for rectal cancer. And so,
And availability of those resources may be an issue too, because they're not available at every major institution. They might be available in 1 or 2 places for the entire country of 30 million people.
right.
So,
So I think there's a lot of a lot of work that needs to be done in that regard. I think that my early sense in, kind of right now is that we need to reach out to the radiologists and pathologists, because staging is such a critical component of cancer care, and it's pretty inconsistent. And we've been, I've already been corresponding regularly with one of the general surgeons, and it's clear that there's a lot of work that needs to be done. And it was true here too. Even, over the last few years, we've been working with our radiology department to standardize on MRI rectal cancer reads, to help us guide our treatment algorithm. So this is not, a unique thing. It's a challenge.
This reminds me. So one of my friends is the head of the global oncology program at UCSF at the cancer center there. And they have multiple collaborations in multiple continents with multiple R01s and all kinds of things. I wonder if I should have her come and give a works in progress talk to kind of get a sense of how they've structured their collaboration, because a lot of this is multidisciplinary, and we're in a surgery specific environment, but most of the work is not necessarily surgery related for cancer care.
Right.
And I wonder if we could think a little bit better about that.
Yeah.
As we're forming.
Yeah. And, I would say that that's particularly true because rectal cancer as a field, if anything has changed in the last 5 years, we've moved more and more towards potential non-operative management for about a quarter of our patients. And so, there's a whole separate discussion about the cultural components, challenges of rectal cancer, right? With changes of bowel habits, sexual function, and then ostomies being sort of the big difficult challenge. And for example, at Corlebu, they don't do ostomies because patients don't tolerate them. So they'll do intrasphincterics and other dissections that they tell us that worry me from a quality of life standpoint to avoid the ostomies. There's also a cultural component and religious component and other things like that. But so it'd be interesting to hear from their experiences of tackling that. So so I think, anyway, I think all those issues are very valid and we're working on it. And I think the fortunate thing is it's kind of at least unified, and the guy in the middle, Sam Deborah, is actually the president of the college going forward. So that does help in terms of having buy-in and diktat, if you will. Not to say he's a dictator. And then on Friday, we went back to Corlebu, and the unit there had arranged for us to provide. They had two patients with anorectal fistulas, and then they had initially 2 patients with rectal prolapse that went down to 1. So we were able to demonstrate those operations to them for that. So obviously, have very different clinical practices. The patients are admitted. It's a surprise to me that the patient was admitted from that I did a demo on fistula on, and I wouldn't have admitted the patient nor put him a bowel prep, but I've discovered that there's a reason why bowel prep is actually not a good idea for an anorectal case for a patient that is awake under spinal and prone. It's things I don't run into my own practice, but they're just things you have to adapt to the situation. So anyway, I think that was actually really well received. One of the big things we did here, and I'm totally blanking her name, but the woman in the middle is essentially one of the young surgeons in the colorectal unit, and she's going to Minnesota on a ASCARS fellowship. But we really try to get the local surgeons to do the operations and have us supervise, because they are general surgeons. They have done a lot of these operations, and it's really just fine tuning their technique, kind of showing them some of the sort of nuances, if you will, that those of us who do this a lot more incorporate in our practice. So we did a suture rectopexy, a lift procedure, and then and I ended up doing a fistulotomy just for a superficial transsphincteric fistula. So current where we are right now. So they've been interviewing. They posted the position several months ago, and then they interviewed and selected their first fellow. They're a general surgery resident from Kumasi. And so the plan is for them to be actually based in Accra at Corlebu at the colorectal unit to give them a different experience from their experience out in Kumasi. And my understanding is they're still interviewing they have got 1 or 2 more candidates they want to talk about and review. I haven't been part of that selection process, but they speak very highly of the person. Going forward, so the next steps from our side, a couple of things we're working on our side. So because of the way the scheduling and time difference, Most likely they'll be joining our colorectal cancer, or actually specific rectal cancer tumor board, which is on Monday mornings. And then that we've been revamping ours because that just started for us like 2 months ago. And then incorporating that with our didactic schedule, which we usually have our lectures after that tumor board. We're still kind of making the changes to tumor board, but that will go forward, I think, pretty easily. And we have most of the paperwork kind of ready to go. And we're just kind of talking with them about how that might work. And as
Would you be willing to record some of those didactic lectures and put it in a bank?
Yeah, we can definitely do that. Yeah.
That's something for us to keep in mind.
Yeah. And they may have recorded the ones that were given in January, February as well. So we could see if I can ask Gifty for those.
Yeah.
Some around the certificate program, as the fellow is going to be starting, I think in the fall, we still need to finalize case logging for them, and what the formative and summative feedbacks exams are going to look like. And it sounds like it's going to be a combination of oral and written. There's not going to be a master's thesis because they've already finished one as part of their fellowship. And then they just like yesterday sent out a series of Friday monthly schedule sort of meet conferences that we'll do online that will kind of jump between being pre-op conferences to discuss cases coming up, journal clubs, and then also doing M&M specifically for the fellows. At least I've advocated, we haven't quite figured it out, but I've advocated for running it the way I did it at Mayo, which was that you kind of review your cases over 6 months and essentially could get grilled on anything that happened, both technical or clinical management on those patients, as well as talking about sort of complications and the management of complications. The hope is that on the U.S. colorectal surgeon side, that we'll be returning starting in the fall to provide additional on-site training, at least at a week at a time. That's kind of to be determined, the exact schedule. But it was clear when we were there that they understand the concepts, they've read the papers, but just the technical parts I think are really important, and of providing the training, and then also I think kind of getting a better feel for the landscape. We're only at Corlebu, and so I think it'd be important to go out to Cape Coast and Kumasi as well and get a feel, because I'm sure it's going to be different. But the idea is to reinforce the master's training, if you will, and teaching, kind of focusing more on teaching the teachers, and so then they can pass those skills on. But I think that's going to require a lot of reinforcement. Ann Lauer is working on getting. She has a couple retired colorectal surgeons that might be willing to spend a little more time, like a month or 2 or longer in Ghana, and that would be ideal, in fact, to provide kind of longer term support for that. So to be determined. I think for us active surgeons, it's a little bit harder to stay more than a week or so. Equipment needs is a huge problem, unsurprisingly. Anyway, that the easiest stuff is sutures, and the right says the sutures and things like that, and that's actually most of those can be worked around. They really do lack most of the open pelvic retractors that we would normally use for rectal cancers, and things like that. So I think we need to figure out how to get them, St. Mark's and Wiley renal vein retractors and stuff that if you're going to do a proper rectal cancer operation, I think are really key. In the grand scheme, those are not super expensive, but we just got to figure that out. We did bring a lot of other supplies, and so we can talk about that. Gifty, I think, is kind of taking the lead, trying to find and apply for long-term financial support for this. That's kind of the thing that everybody has to deal with. And then the plan, I think, is for the fellows, this year's set of fellows, to come out and do their externship in March of 2024, with the idea that they would do about a month with us. It would be an observership, not hands-on because of licensing, but they'll spend a month with depending how many there are, like for example us or Michigan or Arkansas, and then for them to then fly to Boston, go to the American College or the American Society of Colorectal Surgeon meeting, and then in Boston, and before returning back to Ghana. So that's kind of the reason for that timing. And I think that's it. Just these are everybody that's been involved. I'm sure missing people's names, but a lot of support from a lot of people. So let me just stop there. Any questions? I'll put my mug up, I guess, instead of the slides.